Welcome to the EASD web-based lectures. My name is Thomas Meissner. I'm a pediatric diabetologist from the University Children's Hospital in Düsseldorf. And I'm happy to take part in this program today. And I'm very happy to interview today Professor Johnny Ludvigsson from Linköping in Sweden, who is an expert on pediatric diabetes, and he has many experiences over more than 20 years of research, I think. He was honored by the ISPAD with a prize for outstanding research in the field of pediatric diabetes. And yes, I would like to start with the first question related to your lecture. You showed that the incidence of diabetes is increasing over the last 2 decades. And what are the reasons for this increase? And is there any chance to reverse the situation?
As we don't know the reason for type 1 diabetes, unfortunately, we cannot say that we know the reason why it increases, actually. But there are some reasonably good hypotheses. As I mentioned in my presentation, we have this change in hygiene. I don't see how we could do anything about that, more or less. What I think is that those factors related to type 2 diabetes, leading to stress of the beta cells, leading to an increased amount of insulin, like decrease in physical exercise activity, increase in body weight, psychological stress, and so on. Those factors which we normally associate with development of type 2, they may play a role also for type 1 diabetes, although we don't know. And if so, that sort of changes of lifestyle with more physical activity and stop the increasing epidemics of obesity, maybe that I could also decrease the incidence of type 1 diabetes. But otherwise, to do something about type 1 diabetes, we will come in the future perhaps to possibilities to intervene in some way. And we have one study, as you certainly know, a primary prevention trial avoiding cow milk introduction early in life in childhood. If that shows an effect, it may lead to some kind of prevention in certain groups. We don't know. And then we have these immune interventions where GAD, for instance, could, if it works, lead to possible prevention.
Mm-hmm. And the different stress to the beta cell is the reason for the difference between different ethnic groups or different countries, because there are completely different rates of incidence, or is it more the genetic background of a population?
Yeah, the genetic background plays certainly a big role for this type, especially for type 2 diabetes and for insulin resistance. We see that very clearly, that certain, like Indian tribes or people in Arabs and Polynesia and India and Africa and so on, they tend to get more insulin resistance and they have more and more type 2 diabetes. While we in our part of the world, in the Northern Europe, for instance, have another type of tendency to the strong immune system to defend ourselves in this difficult climate, and when we don't use that any longer nowadays and sit in our castles very clean with few enemies, we tend to get immune deviations and autoimmune diseases, for instance.
Mm. Yes, you talked about type 2 diabetes in children and adolescents, which is really increasing over the last years. We have this overweight epidemic, and what do you think do we have to do to prevent this adolescents from becoming type 2 diabetes already in childhood?
Yeah, I think this is we need a change of the whole society, actually, because we have to change and start early in education of parents and in school to get another type of food habits, because we have got food habits which are which is a disaster. I mean, we have everything is big and enormous amounts of energy, and that has to be changed in some way. Then we have also to try to come back to a more physically active situation. But how that could be done, I absolutely don't know, because with these modern computers and this type of lifestyle people have, it's very, very difficult.
Yes, very difficult to change the habits.
Yeah.
And other forms of diabetes in childhood, is there any importance of other diseases than type 1 diabetes or type 2 diabetes for a pediatric diabetologist?
I think it's good to classify. I think it's peculiar in a way that people really don't classify diabetes. In Sweden, we take, in all newly diagnosed diabetic children, we take we do a genetic determination of the HLA types and so on. We measure autoantibodies in everybody, and we look upon C-peptide, at spontaneous C-peptide in all children, to get a classification. Because if a child has, say, MODY type 2, for instance, and perhaps does not even need insulin, it would be a pity if a child continues for decades with insulin, which would be the wrong treatment. So even though these are rather few, I think it's important to know who are the ones with possible MODY and who are the ones with type 2, because it's not so easy to say if somebody is type 2 when they have autoimmune phenomena, certain antibodies perhaps, and also cell-mediated immune deviations. So we have to try the best we can.
Yeah. We all have these patients with positive antibodies or negative antibodies, and on the other hand, low insulin need, for example, and they might be a little bit overweight, and then we don't really know it's MODY, it's type 2, or it's type 1.
Yes. It's not difficult to classify, actually.
When we go to type 1 diabetes, if we start in the beginning, there are several ongoing studies you mentioned in your lecture already. Do you think that there are convincing data that we will have a treatment available in the near future to stop this immune process, destroying the beta cells, and to have residual function for patients with diabetes, with recent onset of diabetes?
I wish I could say. In a month from now, maybe I can't say, because it is so that, unfortunately, and that was a very big disappointment, that both phase 3 anti-CD3 trials failed. And then we have seen a year or so back that anti-CD20 could play some role, but it's a rather small effect and transient, very transient. For me, the most interesting concept is treatment with autoantigens. If GAD treatment can, if the phase 3 confirms the effect we saw in the phase 2 trials, then I think a new road opens. I don't say that GAD treatment in the way we use it now is the final solution, but it is an opening of a possibility, because if we learn that we can use autoantigens in that way, we could start perhaps to know more about intervals, doses, combination with other autoantigens. If somebody, react against tyrosine phosphatase, against insulin, against zinc transport antigen, we should perhaps combine. And we could perhaps start to learn how to combine even completely different treatments like interleukin-1 receptor antagonist and antigen treatment, autoantigen treatment, and so on. So, if it works reasonably well, then I think we start a new type of road and new research. And then definitely, finally, we will have something in addition to insulin.
Okay, that would be good.
I'm more optimistic now than I've been. I've not worked with diabetes research for 20 years, but for 45 years.
Oh, I'm sorry. I looked this up in your CV.
I look so young, that's the problem.
Okay, I'm sorry, Johnny.
And I have been involved in immune intervention trials for more than 30 years, and they have always failed in different ways. This time I'm a bit optimistic.
Okay. But so far we have to use the things we have, and we have a very good treatment for patients with diabetes. What do you think, which insulin do we need, which pump system do we need, what is the impact of continuous glucose monitoring systems, and all the things we have now for treatment of diabetes?
Yeah, you're right that we have rather good treatment. I mean, it's still a heavy treatment. It's a demanding treatment in many ways, but it's reasonably good, and therefore we cannot intervene with too dangerous things, as we actually can offer a reasonably good treatment. I believe that there is a continuous improvement of insulins. And there are interesting things going on. We have got improvements with the insulin analogs, which sometimes improve the situation with a little bit less fluctuations and more stable uptake and so on. And with the insulin analogs to the meals, that's also some improvements. We may get insulins related with where you get effect related to the glucose values, for instance, and so on. So there is a development which I can foresee in insulins. And then you have this improvement with devices. I mean, these small improvements where you get a pen where you are reminded that, did I take the insulin dose or did I not? That sort of small things may play an important role. And then the pumps, of course, they get better and better, and young people understand them, and if they just get motivated enough to use these pumps, I am sure that it can lead to an improvement. And as I said in my presentation, personally, I'm rather fond of glucose sensors. I think they're interesting, they can give a fantastic information, but you must accept and work with it, otherwise it doesn't help. So it's always a combination of motivation, psychosocial support and communication. But then these modern devices will improve it.
Do we have to emphasize more on these things, motivation, psychological support, talk to the patients, to talk to the family, to make groups of patients and discuss the problems? Do we focus too much on insulin dosage and insulins we use and don't really see the patient?
I think so. I think we sometimes tend to forget these absolutely cornerstones. And we are so fascinated of all our new things that we forget that it doesn't help with whatever modern devices we offer unless the patient is motivated enough and accept the situation. And therefore it's absolutely crucial that we have, and I underline this from the very beginning. You must give the patient and the family, both parents, siblings sometimes, if they are grown up enough, and the patient, they must get a clear message. They must understand that this is the situation we have to accept. And if you can do that and then start to collaborate with them, then I think it can work rather well.
Yes, you showed us that the team is very important because there are different centers with different results. If we look on the HbA1c.
Yeah, if you should have a team, then you must work as a team. Yeah. Otherwise, you shouldn't have a team. It's better to work alone if you don't work together. Yeah. But if you really work together and you agree upon that this is what we believe in, that's our aim. These methods we use, we look upon blood glucose monitoring in this way. We use insulin in this way. We believe in that sort of glucose values, and we have these recommendations, and we believe in them so that we say it not only with words, but with a whole mimic, face, body, eyes, tone, everything. And if everybody does that, then I believe in it.
Okay.
And then the team is good, because sometimes the patient has better contact with the nurse or somebody, you know, they talk in different ways with us. Then it's good.
Mm-hmm. Okay. And what's about medical nutritional therapy? There are a lot of controversial discussions how much carbohydrates, for example, and fat intake. And what do you think about this? Is this an important mainstay of therapy to educate the patients on diet?
I think it's more important than it has been regarded for some time, at least in our country. You know, in the 70s, we were very active in educating on diet, and they got special portions, and they had to learn a lot of things and so on. But then the time came when everybody said that it doesn't matter, they get just nervous and stressed, and therefore you can let them eat whatever they want, and they adapt their insulin doses. But it's very difficult to adapt insulin doses unless you know what you should adapt to. In my experience, I think it's easier if you keep certain reasonable rules, irregularities with meals. That's one important thing. If you have certain knowledge on the content of the meal, so that you have some reasonable feeling for how much carbohydrates do you have, and is that rich in fibers or not, and a little bit more about the meal. Otherwise, it's impossible to adjust insulin. It doesn't work. So I think they should learn, as in a reasonable way, not to make them so stressed that they get anorectic or bulimia or that sort of problems, but try to get them interested. It is rather interesting, actually, and some even young people, even teenagers and children, may get rather interested when you start to discuss the food and try to get them to understand what it means.
Yeah.
Physical exercise, if I may add also, it's something which also tends to be forgotten, because that was one of the cornerstones. But now people don't talk so much about physical exercise or physical activity, I would say. But I don't say that you should use it as a drug. It should not be a medicine. But it should be part of normal life. And if you can get it into a part of normal life, then I think it's valuable.
It's so difficult to teach our children to have a healthy life, I think, but it would be even more needed in patients with diabetes, I think.
Absolutely. I mean, we have two unhealthy lifestyles, and that includes everybody with or without diabetes, and that's a problem. And we have also, of course, especially in our country, I don't know so much about other countries, very many and serious psychosocial problems. When a child comes nowadays with newly diagnosed diabetes, we are not talking about two parents normally. We are talking about 4, 5, 6 parents, different, coming from different areas. And they are living 1 week here and 1 week there. That should be forbidden in connection with diabetes, but it isn't. So we have to work with that. And that is a very important thing. Otherwise it's...
So if you have a patient, what's your aim for long-term metabolic control? Do you try to find an individual aim or target for the family based on age, for example, or on social or familial background?
No, not really. Of course, you have to have an individual aim in that way that if you have somebody with a very difficult situation and that patient has a little bit higher hemoglobin A1C, you should always work with his or her situation and try to reduce that. But the aim is the same. And the aim is, in our case, we have the aim of 50 millimole per mole as the aim, which is the same as, what is that? That is 6.9 in DCCT values, I think. Something like that. That's the upper, it should be below that. And that is true for all, and it's absolutely true for younger children, because in some countries in the world they let younger children have higher hemoglobin A1C than school children and teenagers. I think younger children, they can very well have low hemoglobin A1C values, sometimes much lower. But it should also be so for teenagers, that they should keep to that aim, and you should be very clear about it. Because if you start to say that it's okay for you to have 8% or 9%, they will have it.
Yeah. We all have this typical teenager who doesn't want to measure his glucose, who doesn't want to give him insulin, and who has a very bad metabolic control. And we talk to him again and again, and to his family. What do you do in this situation? What are your measures you have to improve the situation?
It's extremely difficult to say, because it differs a lot. Sometimes we have, of course, to discuss. Somebody else perhaps should discuss with you. I mean, I say sometimes to say a teenager that I've tried everything. I've been, kind, and I threaten you. I've used hard words. I've tried everything. It doesn't work. So maybe it's better you see somebody else. Would you like that? But sometimes I also try something completely different and say, okay, now I'm the patient and you are the doctor. You are the doctor. Explain to me so that I understand. Mm-hmm. And get me to show me how I should be motivated. This is a very interesting thing, You can get a teenager to start, first they get a bit confused, but so you can learn from each other. Yeah. If you can collaborate and say, okay, do you want to see me? Is it of any use that we meet more? If they say, oh, yeah, they want that, okay, what should we then agree upon? Sometimes I write it down. We write a little contract. We agree upon that this is what you are going to do and this is what I'm going to do. And now we decide. We see each other again in 1 month. Mm-hmm. And this is the aim of it. So we have to try to have rather short-term goals and realistic agreements. Yeah. And sometimes it works, but we all fail. I failed.
Yes, in your lecture you talked about the research over the last years, over the last decades. What do you think are the major points for the future, for the next years? What should we focus on in pediatric diabetes?
Yeah, I can't really say, because there are so many different areas we could focus on. I think it's good for those who work with improvement of this use of the modern devices and so on. That's one thought of research. Personally, I'm more interested in sort of radical interventions, because we should be able to stop this disease, and we should be able to cure. I think it's, as I said, it's a shame that we can't cure and that we can't at least preserve insulin secretion. So that sort of studies I'm enormously interested in. But we need to work in different areas. Prevent complications, improve treatment, preserve insulin secretion, prevent diabetes. I used to say, I can perhaps almost end with that and say, I always have said to my patients, before I get 100 years old, we will cure the disease. And now they are very hopeful. So I think it can't be very long. Fantastic.
Okay. Maybe a final question. Could you please give me practical advice? The next patient with his or her manifestation of diabetes is probably just around the corner. And we know that it's very important what we say in the first conversation. What are your suggestions for me on the topics. How do we have a good situation with?
I would say two things. For the first, I would be, I'm always want to speak with the child together with both parents. Mm-hmm. Absolutely. They have to come. And if there are older siblings, I want them also to be there. And then I would be very honest, but still optimistic. I would be very honest and say, I would be very sorry if I got that. Diabetes. It's a difficult disease. It's a serious disease. We can't cure this disease. It's a rather heavy treatment. But you don't get this normal life any longer until you get cured in the future. Because I hope you get cured. But if you learn to treat this disease, and you will learn it, then you will get a fantastic life. You will get a happy, wonderful, exciting life. Absolutely. But you have to accept from the very beginning. If I can convince them and we can agree upon that, then I think they have a very good start.
Mm-hmm. I think these are very good closing words, a fantastic life. And for me, it was a pleasure to do this interview. Thank you very much, Johnny. And to all the viewers, thank you very much for joining the program. It was nice for me.
Thank you very much. Thank you.